Next week, Canada hosts the G8 and G20. There's a tremendous opportunity for Canada to show leadership to the world on this all-important topic. And next fall, the Millennium Summit in New York City will give us one additional opportunity to build on this momentum. The second opportunity we saw for ourselves really speaks to the unique aspect of the summit as we see it. And that's the role for the private sector to intersect with global health community to build sustainable models for business and global health in only the way that the private sector can do, with innovative and dynamic models for business.
This is a meeting that combines the worlds of science, of business, of politics, and of policy. And that's a very potent mixture. And I think that the challenge and the opportunity of this meeting, as Michael has said, is to actually make things happen. And I don't think that any of us can predict exactly what will happen, but please do take the opportunity to talk to the people you don't know, as well as obviously the people you do, because it's amazing what does happen.
It's such a great pleasure for me to come to the summit meetings and see people that I've met at these meetings, specifically in prior years. And I'm sure that's true for many of you, and my hope is that meetings between people that are created here at this venue will lead to improvements in global health. I'm sure they will.
This meeting is a very important meeting in this context because it draws together policymakers, academics, people from industry and the private sector, donors and recipient countries. This is a great place in which we can work together to forward this issue of maternal newborn child health. Now, what I want to make a pitch for this evening is the absolute requirement for innovation to take this further. We have made great progress, but to make further progress, we must have innovation. Now, innovation, sometimes people assume, implies, molecular genetics at some basic level, and sometimes that's what it requires. But innovation in this space can be very, very simple. A clean knife to cut the umbilical cord can save lives. Washing the cord with a soap, surgical soap, saves lives. One of my favorite interventions is this intervention called kangaroo baby care. Have you heard of it? This is one where shortly after a baby's delivered, the baby is strapped to the mother's chest in the manner of a kangaroo mother and her baby. Now, this is, on the one level, very simple. It's about warming the baby. It creates bonding between the mother and child. It promotes breastfeeding. But there's exciting research that says more is possible through this simple innovation. There's clearly improved immunity in the child that undergoes kangaroo breast care. Now, there's another interesting cutting-edge scientific understanding that there's this field called microbiomics, that the human body has more living cells in it which are bacterial in origin as opposed to human in origin, and those bacteria can have a huge impact on the physiology of the human being. And in this case, it appears that the bacteria that populate the skin of the mother can be transferred to the skin of the child through this, and the net impact is protection against one of the most feared causes of death in children, that of sepsis. So very simple solutions, others like a small squirt of vitamin A or zinc, these things have been proven to save lives.
Had we met here 1970 to discuss maternal and child health in the world, there were two indicators we would be concerned with. And those indicators are shown on this graph here, where each bubble is a country. First, it was fertility rate, the number of children per woman. 1 and 2 here in the Western world, and 3, 4, 5, 6, 7, up to 8 children per woman in what we used to call the developing world. And here, under child mortality rate, what we have measured up to 5 years for a long time. And that was up to 100 in the Western world, up to 50 there. And then what we call developing countries started by 100 to 200 to 300, and some countries even beyond. Has things improved? This is my first question. Has all those efforts done by communities, by countries, and by the international aid community, corporate sector, and research, have they lowered child mortality? Have they enabled families to go for fewer number of children in which they could invest more? Let us see. I will start the world in front of you. Here we go. You can see that the investments in vaccine and in infectious treatment, in diarrheal treatment, in malaria, and in better nutrition, that decreased child mortality, and it increased the take-up of family planning. In here, the green countries are in the Middle East, the yellow in Latin America, and this is South Asia and the rest of Asia, and they all move towards this. And now, in the last years, we find most countries in the world have less than 3 children per woman and less than 50 in child mortality. A complete success story. No, not complete, because there's still a big unfinished agenda. But it's very difficult to draw the line between the Western world and the developing world. I'm unable to do it, so I get confused when you talk about developing countries. Because we have the emerging markets down here, which are now having a health and a fertility situation as we had in West Europe and North America in the 1950s. And then we have the poorest countries here, Afghanistan up there, which is a completely different situation. Now, what I'm going to do now with this is that I'm going to try to tell you at what age the children are dying here. 30 to 40% of child deaths are in newborn in the world. About 30 up here, then 40 here, 50 down here. It's a major part of those deaths from 0 to 5 years occurs in the first 4 weeks of life. And those deaths are very closely related to maternal mortality. We must not be guided by the division of disciplines for physicians or by the character of the indicators we have been used when we act and analyze. So look here. We look at the causes of deaths of the newborns and for maternal death. Asphyxia, not getting enough oxygen during the delivery, is a very common cause of death in the first four weeks. The same thing is killing mothers. That complicated delivery is obstructed labor. Infections in the newborn is very closely related to infections in the mothers. And there's very many similarities between the causes of maternal death and of newborn death. There are some special causes which have been mentioned here on both sides also. So this means that we have to look into what is different on saving children's life beyond 1 to 6 months and what is needed to save it before. And the major difference is that to save those lives, part of it can be done by frontline workers in the communities and in the primary health care. But a large part of it have to be some sort of hospital service with other technologies available. And they are not so easy to provide vertically. It has to be a health system in which they are integrated. So what about the maternal mortality? How far has it come? Well, let me show you maternal mortality in the world. Each bubble here, the size of it shows the number of maternal deaths in each country. And you can see that the problem maternal death is mainly a problem in parts of Africa and in South Asia. And the number of mothers dying due to pregnancy and at delivery is between 300 to 400,000. Why do I have to be so vague? Because it's difficult to measure maternal mortality. It's much easier to measure fertility rate, number of children per woman. We do this in most parts of the world, especially in these countries, by censuses or surveys, where a representative sample is picked up and we go and visit the home. We knock the door opens, the children come out to look, and we count them 1, 2, 3, 4, 5. It's quite straightforward to get fertility rate and to get census data. But to get child mortality data, you have to sit down and interview, and you must have the confidence of the mother. And that requires a much more qualified surveyor. But when you want to get maternal mortality data, the problem is that when you knock the door, no one's open. Because the death of a young mother leads to the end of that household. The widow will go back to town to work more, to remarry. The children would be taken care of by relatives. To measure maternal mortality, where we have no register and no cause of death registration, have to be done by sisterhood method or by sibling method. We have to ask people whether their sisters have died or not. And that's much more complicated. So my long story about this is we have to accept that we don't have precise measurements of maternal mortality, although very good advancement has been made recently. I'll change the map over to a chart here. Look, I morph over and I show income per person here instead. $400, $4,000, $40,000. And here now the maternal mortality ratio per 100,000 live births. You see, it's the countries, of course, that have very high maternal mortality ratio where you find most of the maternal deaths. And in fact, you see, it almost stops between $3,000 to $4,000 in purchasing parity. It's not really a problem in the developing world already to here. The emerging economies has managed to get maternal mortality and newborn mortality down to relatively low levels. The bulk of the problem is up here, and we must have a bigger and more clear focus than just saying developing countries. Now, when we move up here, we ask the question, do these countries then have to become rich first before they can get this mortality down? I'll give you an example from a country I know relatively well, a poor country called Sweden in 1800. Sweden was up there. For a strange reason, we have recorded death for a very long time in Sweden. It's a sort of morbid personality of the Swedes, you know. So 1800 is there, 1900 there, and 2000 is there. And we had almost 1,000 per 100,000 in maternal mortality at that time. And then what has happened is this. We deployed frontline workers, midwives were trained, and they were deployed in almost every parish throughout the country. And that gradually and slowly, together with economic growth and other improvements, brought maternal mortality down to almost 200. Can you see? We made it almost down from 1,000 to 200. That actually one component can be taken care of. As Tachi said, those small measures of a cleaner cut of the umbilical cord, that simple technology. I would say industrial produced soap is very important for this. Improved hygiene. Sri Lanka is another country that happens to have recording of maternal mortality that are relatively useful already since 1900. Look, these weren't good years. Tanzania were poorer, didn't have so much midwives, and did have malaria. And Sweden increased. Why? Because here we got illegal and unsafe abortion that started to kill women. And our government and parliament banned the importation of condoms from 1909 to 1936. We call it the Taliban period of Sweden almost. It's quite unbelievable today that was the policy of the Swedes. Now, in the end of the 1930s, then something new happened. That's when the new technology became available, and this happened to maternal mortality. Look, isn't it a success story? Modern hospital service, antibiotics, blood transfusion, ambulance services, and it went down like this. And Sri Lanka did almost the same some decades later. Was that because they got very rich? Let me change the horizontal axis from time to income per person. No. Sri Lanka should be honored for having got maternal mortality down to a very low level when they were still at income level of where we have to focus today. But they had a special context. It was a plantation economy. They had an infrastructure of road. They have a high educational level, also women. So they had another situation. And it's very important to analyze maternal mortality and newborn mortality in the whole setting of the society. So this is more or less where we find these countries today. We can do like this, and then we can show the entire world. It looks like this. I showed it before, and I can go backwards now due to the new time series that recently were published by the Institute of Health Metrics and Evaluation in Seattle. And they can bring us back to there. We know nothing beyond 1980. We are blind. Here we start to see now. And they have been meticulously documented, the methods. And look here, we have a movement down most of the world. It's quite hopeful. But this can be speeded up by more innovation and by better methods, as we have heard. Now, what does it take? What does it take up here? It's a special situation. The maternal mortality is mainly in rural area. Where it is in urban area, it should be possible, relatively easy to get it down. I would say there are three different things needed. It's the technology we heard about. We need new innovations, but we also need provision of existing technologies. Everything from instrument of treatment and examination, drugs, lab equipment, and equipment for blood transfusions. But we also need health systems and health services. This ain't as easy as distributing mosquito nets or running vaccines. Those are more separated. This is an integrated part of the health system. And that's a financial situation that has to be solved and innovated also. I like when Tachi presented financial structures as possible innovations. And we can also see that the context is very important in these poor rural areas. And that's why corporate sector becomes very interesting and important beyond the direct interventions in the pharmaceutical field and the medical field. Because what do we have in new technology? We have misoprostol, but we also have other technologies. I'll come and end to that. We need utilities. Electricity is very important for decreasing maternal mortality and newborn mortality. It's mainly occurring where people don't have electricity. It is important to have infrastructures in road and transport. And the great news we have is the cell phone and the increased communication. And I just had a short talk here with Ali Mufuruki from Infotech in Tanzania at table 8 here, who will present later, you know. And I think you may represent the sector who have done most for maternal mortality in the last few years in Africa. You come from Tanzania. Because the ability to communicate and to arrange for transport and to raise money like payment through the cell phone system, that's an enormous innovation. And this now, you said in your country you have a reach all out in all villages. So please think about the corporate sector not only as the investors in the medical field and in the health field, but also that wider context. Because really to get down newborn death and maternal death is to alleviate the deepest poverty, which is a shame, and it's also very irrational for the world to have it. It is dangerous for the future. We can get it done. Let's do it. Thank you very much.